Good morning, everybody. Welcome to the inauguration of the Master in Minimally Invasive Surgery and in Pediatric Urology. Please share the presentation from Regia.
Hello, Professor. Do you see your presentation?
Okay, next, please. This year, next slide, please. This year is the inauguration of the 16th edition of the Master in Minimally Invasive Robotic Surgery. And the next slide, please. The 6th edition of the Master in Pediatric Urology. I hope, next please, I hope it will be the last time that we do the inauguration online. Next please. Even if the years of the pandemic have made us discover new digital teaching methods that have allowed us to maintain the quality, next slide please, level of the master. Thanks also to the competence of colleagues who are part of the faculty. Next slide, please. Next. This year, we will return to carry out activity on simulator and animal model during the clinical stage, as this period with virtual reality, augmented reality. Next slide, please. Next. 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 Next, please. And the use, next slide, of artificial intelligence, we have improved the simulation center. Really, the COVID era, some people say nothing like before. No, but it will be very different. And for this reason, next slide, please. We work with virtual reality, augmented reality, and artificial intelligence to improve the simulator center and to improve the our master. Next slide, please. The simulator center, we have the animal models like this picture and the electronic simulator. Next, please. And this explains the choice of the topic of this afternoon. The metaverse in pediatric surgery, virtual reality, augmented reality, artificial intelligence, simulation, and use of 3D printers. We have invited a very famous speaker, Professoressa Silvana Perretta from Strasbourg, from the University of Strasbourg and the IRCAD of Strasbourg. My friend Jean Bredeau from Nice, Edu Thomas and Marco Dimitri is residents of Bologna, and Mario Messina is the director and coadjutor of the School of Specialty in Italy, and speak about this topic. Now start with the presentation of Professoressa Silvana Perretta from Strasbourg. They speak about the digital transformation, smart technology for intelligent surgery. Please, Silvana.
Thank you very much for the kind introduction, and thank you for the kind words. Happy to present today with this stellar panel of faculty on such an exciting topic, at least for me. Then we will see if for the public. So we, over the past 30 years, we have seen a tremendous evolution in surgery. We have seen changes in the concept of the disease, changes in the surgical techniques and the technology that we use when we operate, changes in the environment where we practice, but mainly and probably most importantly, changes in the expectation of the patients. And if we look at the evolution that data and smart technology and video imaging brought to surgery, you can start with just the sight. We now see what we're doing. We have high quality images. We have high resolution. We have a way to enhance what we do with fluorescence. We can use near infrared imaging and ICG in order to achieve better oncological outcomes. For instance, when we perform a gastrectomy, we have more complete resection, more lymph nodes that we can retrieve. We can standardize the technique. We can also better understand how the pathway of the dissemination of the cancer work thanks to enhanced imaging and more data. We could potentially prevent complication from happening. This is a case of the use of ICG in esophageal surgery. We can inject ICG and we can take a look at the vascularization of the stomach that has been brought up to the neck and see if in fact it's viable or not, and we can go ahead and do the anastomosis. The environment where we practice changes. We do have now a hybrid room with the opportunity to re-register the images and fuse the images of laparoscopy and CT scan or the Pheno robot or the MRI while we are operating in order to really deliver personalized, precise surgery. And today, really, thanks to this evolution of all these images and all this data, we can really say that a surgery can be any of the act that you see represented in this slide. It could be performed with your hands in open surgery. It could be performed with laparoscopic surgery, with robotic surgery, with a flexible scope used to perform endoscopic resection or also transluminal resection. It could be performed using a percutaneous needle or using simply a different form of heat or cold or a gamma knife in order to destroy the tumor. So literally any act performed with instruments or the hands of the surgeon could be considered a surgical procedure today. And as our very good friend Rick Satava would say, we live in a world where now medicine really switched from the industrial age to the age of information. And this is why one of the reasons why we built a very strong research team here at ERCAT, because we were convinced that data could really lead to the future of surgery, which to me is also related to education. And I do know that there's going to be a fantastic lecture on simulation education in surgery, but I just wanted to stress that education today should be digital, intelligent, personalized, using competence versus number, quality controlled, responsible, and open. And all of this is possible thanks to new technology, smart technology, and the sharing of what we do thanks to image-guided surgery and laparoscopy. And of course, we started this smart world of sharing, openness very early with the development of web search, which is the virtual university. And this is something very important because it's really surgery without borders. You can learn new techniques, you can be exposed to new technologies. You can rehearse a procedure that you haven't done in a while in order to prepare yourself. And we have now more than 450,000 members, all specialty together, including pediatric surgery. And simulation is very, very, very important in surgery. Yet we are not to the point where aviation is. When you're learning how to fly, you can use simulation in order to reduce by 40% the time to certification. And we now have residency specialty program in surgery that are very long. Probably they could benefit a lot by the inclusion of simulation. We can use simulation preoperatively. We can create, thanks to CT scan or MRI, a holomer of the patient, a 3D clone of the patient. And we can learn, of course, anatomy if we are junior, but if we are more senior in surgery, we have more experience, we can decide whether it's the best approach for the patient. You can literally navigate through a tumor, for instance, and decide if you want to attack the tumor from a percutaneous way or use laparoscopy or using a combination of different techniques. And of course, we can also fuse the real with the virtual model or the virtual reality in order to obtain augmented reality. And since 5 to 6 years ago, this was something that was extremely difficult to achieve. And today it is still difficult, but we understood, at least at our institution, who has been one of the leader institution in this particularly difficult field, that if we do use something very simple, such as ultrasound, to really scan constantly, for instance, the liver or the abdomen of the patient, we can re-register the pre-operative image to the intraoperative image, and even if we are moving things around and we are actually changing the anatomy of the patient, because that's what we do as a surgeon. So this is something that probably is going to become a reality in the near future in every single OR. But we can go beyond this, and we could really mix a reality thanks to the metaverse, which is this digital space where we can share surgery and share different practice. And just want to show you a little video that I think is very nice to me. This is a thoracic surgeons, very nice thoracic surgeons from Rouen in France, and Jean-Marc Bast. And what he's doing, he's superimposing the 3D model of the patient that was acquired with virtual patient technology that we developed here at ERIC, and it was then acquired by J&J. And he's saying, you have the impression that you can see the patient by transparency, and you can really put your hand inside. And he's saying, I don't have my patients, I just have my model. And he's teaching his junior how to place the trocar and how to correctly enter into the chest. And this is very much impressive. So surgery, of course, became much more complex, while in the past it was something that very simple, probably not so effective, but relatively safe, to something that is very effective and potentially very dangerous. Why? Because the OR and surgery is a complex process. The OR is a complex environment. It's high stakes. You work in teams. You're not alone. You have a lot of technology. You have a lot of data. Not only the data that you have while you're operating in your operating field, but you do have the data from the energy sources. You have the data from the anesthesia machine, and so on and so forth. And that is the reason why up to 65% of medical error can happen in the OR. So smart technology and artificial intelligence can help us to sense, extract, and assist us in what we do. And this is an example of how it can be used. It's the very first case that we performed now a year ago of a AI-guided cholecystectomy. And this is a system that allows to instantly, real-time understand the anatomy and assess the triangle of safety at cholecystectomy. So you can see real-time, and the image is not very pretty, but I can guarantee you that there are years and years of development behind this this image here. The computer can automatically recognize the cystic duct, the cystic artery, and the CBD and the gallbladder in order to assess whether whether we achieved safety and appropriate dissection before cutting any of this structure. This is another example from Amin Madani that was published a couple of years ago. They did a fantastic job in assessing the go and no-go zone. Very similar principle, always focused on the critical view of safety. But you can see here that instead of recognizing the structure, they are recognizing area of possible dissection, safe dissection, and unsafe dissection. You can imagine that this that is done for and being achieved for cholecystectomy could be extrapolated to a multiple other procedure where there are some areas that should be no-go zone and dangerous zone. We've done something similar with the TAP procedure. We picked the TAP procedure in the transabdominal peritoneal hernia repair because, as for cholecystectomy, is a very well standardized procedure with a very well identified different step: the peritoneum window incision, the dissection of the window, the hernia dissection, the closure of the window, the placement of the mesh, the fixation of the mesh. And so machine learning could identify all these steps and recognize them intraoperatively. But in order to understand whether the surgeon was doing a good job or not, we had to find not only dissection steps, but also ways to measure how correct what was the quality of the dissection. And we identify several important main landmarks in order to teach the computer to recognize a correct dissection. And this is now done real time. Automatic real-time monitoring could also tell the difference in expertise and in competence. And this is very important because analyzing the whole surgical footprint of the operation, you can analyze the footprint of the surgeons and really deliver a report of competence that will allow the surgeons really to focus only on the task that is not doing properly without having to rehearse the whole procedure. So you have personalized, precise mentoring and teaching. We apply the same philosophy to endoscopy. We are very keen in allowing a greater portion of the obese population to be treated. You know that surgery treats only 1% of the adult population, and we have been working on developing gastroplasty by endoscopy, which allows to reduce the volume of the stomach and shrink the stomach in order to facilitate weight loss, and with very, very good results. So what we have done is standardize the procedure and trying to match preoperative data with intraoperative data and postoperative data in order to identify the best technique and the best indication for this surgery. So it's another way of using AI to predict success and failures. And you could go even further. You could mix simulation and data science and reality and a virtual environment. This is a simulation that we have developed in the house, always also for ESG, endoscopic sleeve gastroplasty. And what you see here is that you can have a 3D reconstruction of your patient, of your bariatric patient that you're going to operate on, and you can really mimic and rehearse the procedure before on the 3D reconstructed anatomy. And the simulator not only allows you to understand the tissue-device interaction. This is a suturing machine, but also allows you to understand the interaction of your grabbing and your suture with the peripheral environment, with everything that is outside the stomach that could be inadvertently caught in your suture. So personalization both for the learners, the trainee, and for the patient. We can take it also to another level. We can establish an alphabet of moves in endoscopy and in surgery. We can dissect every single moves, in this case of the endoscopist, in order to create a coding that we can use to simulate the endoscopic gesture. So what we have done, we have registered and tracked the motion of the operator and the scope together, both in vivo and in vitro. And then in the clinical setting with the patient, we synchronize this finding in order to provide the best possible simulation. And here you can see the Xsense technology, which is a suit that is being used to for 3D movies, that is being used in DOR, and is actually capable of recording 17 different points of movement in the body. And we use the Aurora tracking device in order to record the motion of the scope. This information have been then reworked by the SOFA organ-based bank in order to understand the tissue interaction with the simulated environment, and then injected into a gaming simulation. And this is what we dream to do in the future, actually in the present, because this device already exists. This is one of my students, Maria. She's using a plug-and-play device, which is a mock-up of 3D mock-up of a standard scope. Of course, is a fake scope, but she's using it to navigate and to learn how to perform endoscopy at home on her computer with the technology that I've just mentioned before, that has been extracted in the OR. So the concept here is to democratize the use of plug-and-play simulation to bring the education to the students and not the students to the education. We learn the hard way during the COVID. Other companies are doing a very similar thing. This is a very funny game that you can play on your mobile phone, and it's just to entertain yourself with some, I would say, more intellectual games while you're waiting for the train or waiting to get your coffee in the morning. It doesn't, of course, have any interaction in terms of moves, but it's another example of smart gaming and simulation. I think education should be smart, but smart in the sense that it should be responsible. If you want to standardize and democratize the use of laparoscopy, endoscopy, and even some more complex technique, we have to find a way to reduce the costs. And we don't have to think only about the more developed or more the East or the West, where we have more wealth, but really how we can globalize education. We can use ex vivo model, we can use in vitro models, and even simple solutions that will teach you how to do more very complex tasks. But you could also use AI in order to assess the performance of students. We've been collaborating with SAGES in order to objectively record the performance of the trainee when doing the FES, which is the fundamental of endoscopy, of surgical endoscopy test. This is a test that all the surgical residents in the United States have to take in order to be board certified. And thanks to machine learning, we could automate the task recognition so that the student is capable of taking this test in a testing center. It does not require to go and somebody to be there and subjectively measure the quality of their work. Another way to democratize in a smart way surgery is to do a telefenestration in every single OR, allowing the clinician to virtually scrub in any operating room, such as claims to do proximity, with the opening the door to virtual collaboration and virtual mentoring or power coaching, if you will, mixing reality and different kinds of technology. And this is just an example of the interaction. It is very simple indeed. You're just sharing a screen and sharing motion on a screen and a video with your coach or your mentor or your proctor, which can be, of course, anywhere in the world. I think the nice job that the company did is to be a connector, a network between different physicians and different facility. And I'd like to end with an invitation. If we live in a smart world, we should understand data. So if you're willing to work with data scientists, surgeons, and researchers from all around the world, you're more than welcome to join our summer school of surgical data science that is going to be held next July. And with this, I thank you very much for the opportunity to speak.
Thank you very much, Professoressa Perretta. For our is an honor to have you. And now I ask to the audience if you have a question for Professoressa Perretta. If you are interested, please raise the hand. Any question? Gargano. Tommaso Gargano, please.
Thank you, Professor. Thank you, very nice presentation. Very congratulations for this lecture. I have a question for you. I think this technology is wonderful, it's expensive, very expensive. There is, according to you, the possibility to rent instead of buy these devices for the small center of pediatric surgery. What do you think about?
I'm sorry, but I cannot hear you at all. Maybe
I don't.
Professor Lima, if you can.
Yes, Tommaso is not ideal. Don't we hear well you? Please use another microphone because this is not good.
Okay, you listen me?
Yes, much better.
Well,
sorry. Very congratulations for the lecture. I want to ask you this question. This technology is very expensive. According to you, what's the possibility to not buy but rent this device
Tommaso, the microphone don't work. Please use them.
Sorry. Now,
I think the question, let me see if I got it right. I got expensive. So I think that your question was, this technology seems to be expensive. What can we do in order for everybody to use it, correct?
Do you listen me? Do you listen?
Yes, a little bit better.
Oh, do you listen me? Okay,
yes.
sorry, but so there is the possibility to rent these technologies, these devices, instead to buy for the small center of pediatric surgery.
Yeah, sure. I mean, everything is possible. It really depends. I can speak for myself. I cannot speak for the companies, but we, as I showed in the presentation, we really took a great care to reduce the use of animal, of course, for ethical reason too, but also to build simulators that are just as effective as the others that are much more expensive. So I think that you can rent simulators, and you could also look into less expensive simulators, because a lot of the big simulator, for instance, for endoscopy, like the GI Mentor, they're not, they're just as effective as the smaller that are less expensive.
Thank you very much. And my colleagues have another one.
Thank you, Professor Perretta. I have this question. I've seen this model of augmented reality that follows the traction of tissue while the surgeon is operating. But are there possibility of errors or of mistakes? How much precise are these models?
It's a very good question. Those are at the very early stage, so I wouldn't think that's 100% precise. But if you're talking about the AI models for cholecystectomy, for instance, you do not need a millimetric precision because being a surgeon, you should know anatomy. So the structures are not millimetric. So that's pretty good already. If you're talking about delineating a tumor, talking about resection margin, I think that there you would need to be extremely precise, and probably the technology is not yet mature to provide that level of precision. But I think that the combination of smart imaging such as ICG guidance or probably cancer-specific markers and visual inspection, it will allow you to have a much more precise identification of tumor margins.
And the last, regarding telemedicine, do you think we are in a training phase, or you imagine that one surgeon can perform a procedure from one side with other surgeon on the other side of the world, and in case of problem, what we do? If,
well, that's a nice question, because I am sitting in the center that did perform the first telesurgery back 20 years ago from New York to Strasbourg. It was a case of cholecystectomy, and the whole operation was called Lindmer operation. So it is possible. It's very difficult. It's not something that you could do every day. But I do believe, since we already done it, that yes, it will be possible, and robotics will allow us probably to do that even sooner. I think that this is going to be the future.
Thank you very much.
Thank you very much, Professoressa Perretta. And there is any question from the audience? From the colleague? No, thank you very much. Thank you.
Thank you,
Ms. Perretta. And now I invited Jean Bredeau to speak about the pedagogic principle in surgical training, application in simulation. You are ready, Jean?
Yeah, thank you so much, Mario.
Jean comes from Nice, Pediatric Surgery of Nice. Thank you very much.
Thanks to you, Mario. Thank you for the invitation. I'm afraid after this wonderful talk we just had, we go back to the antiquity and to the really basic things of pedagogic value and pedagogic concept. But if we think about antiquity, many things has been discovered during antiquity. So let's talk about that. So I will just try to make a small focus of the real pedagogical principle in surgical training and what is used in simulation and why we always need to keep in mind this principle. So before and now, when we want to train in surgery, we had books, we had to see our senior and having sometimes, most of the time, some feedback. And after we need to try again and again and again the situation to make a skill, to be able to be efficient on this skill. And this, we can say, concept of learning is either for technical and also for non-technical skills, not only for technical skills, but also for communication and diagnosis and so on. So in this case, if we make a comparison between the events that can happen when you are doing technical or not technical skills, there is a link between the experience and the risk for the patient. And at the beginning, when we try to do something, if we don't know anything, we will make a fatal error. This will increase drastically the risk for the patient. Then we can sometimes be lucky, but there is no capacity to reproduce the skill. Then the gesture is not yet accurate. It's a bit because of a lack of recurrence, and we have minor errors. Then there is no errors, and in this case, there is a mastery of the gesture. And if we compare this to the risk for the patient, as soon as we will get definitely efficient, the success will be reproducible, and the risk decrease drastically. So based on this, in fact, we need to have in mind the cognitive principle in simulation and in training. And the first one, when we want to set up a program, a curriculum in simulation, whatever it's for skills or for communication, there is the need that we all know, the need of curriculum alignment. The curriculum alignment is to think about what is our population of learners, what are the objectives, the learning goals and the objective, what is the best device or the best scenario or the best organization to learn this objective, and what is the feedback and assessment tool you get, which evaluation you will do. And this curriculum alignment is definitely the major need in all pedagogic curriculum, especially when you do simulation, in my opinion. The second one is what we all know about the learning process and the Mailer's pyramid that everybody knows. The fact is that, in fact, if we go to the Mailer's pyramid, if you are just able to reproduce the thing and to explain it to a student, it means that you have an experience in this skill or in this communication. So it means that when you are doing simulation, you definitely need to use older students to learn to a younger student, and to have what we can call a tutorial system for the knowledge. The third one, which is very important, is the mental load, we can say, when we are trying to learn something. For this mental load, everybody knows that, but when we are trying to learn something at the beginning, if in the same moment you get your phone ringing, you have a colleague that asks you something, and you have many, we can say, mental load, you will have a lot of difficulty to learn and to get the memorization for learning. So it means that when you are doing simulation, you need to have always a step-by-step process for your student. And the step-by-step process for your student is that they need to have very huge mental energy just to memorize the first step. Once the first step is, you get the memorization, you can move to the second one, the third one, the fifth one, and so on and so on. And it's also why it's very important to be fixed of what is the learning curve of the first step, then the second one, then the third one. Because if you want to get a good evaluation of your student, to be sure he has the good acquisition of the skill, for example, you need to be sure that you will, doing your evaluation, you will be focused on the right thing. So it means that your student has to be free of any perturbation at the beginning, then you can increase the thing. But at the beginning, just also for skills, especially in surgery, when you need to have sometimes automatic skills, at the beginning, the mental load will be enormous. So you don't have to mix all the things at the same moment. It will be really a gradual a scale teaching, we can say. The fourth one is what is called the Dunning-Kruger effect. So the Dunning-Kruger effect is something which is very known through professional musician, or very good sportive and sports people, is that when you will, at the beginning, learn something, you will have disconnection between your confidence and your efficacy or your competency. And what is definitely sure is that when you will start to learn something, a skill, for example, we can imagine simulated esophageal atresia repair, for example, in thoracoscopy. At the beginning, you will feel it's very difficult. Then after the first time, you will feel very, very, very confident. And when you are doing repetition, by time you will see that this topic is not fixed, this one is not fixed, this one is not fixed, and so on and so on and so. And by time you will feel that you don't know anymore anything. And then step by step, you will be able to be confident with the regular efficiency. And this regular efficiency appears when the learning curve is definitely finished, we can say. As opposite, when you will learn something at the beginning, in fact, the problem is that you have a very intense forgetting curve. We all know, you can see on this post graph, we all know that when you are just learning something in, we can say, half a day after, you have lose half of the memorization, and step by step, the memorization will decrease. It's why it's very interesting in simulation to use the repetition of skills. Whatever the students feel is able to do something, he is able to do, we can say, a plot transfer, for example, on FLS, or a situation. It's very important to make him doing repetition and repetition and repetition, because it's not to be sure that he is able to do things, but it's to be sure that he will not forget things. And this is very important. So in all the curriculum in simulation, I recommend, we can say, there is a need for repetition, and you will never validate one exercise in one time, but you will need to have 2, 3, 4 redo to be sure there is a stability of the competency. So one of the other important thing is when you are doing this, it's according to the mental load. When you are doing a technical skill, the first time you are doing this technical skill, you need to create an encoding, a conscient encoding. And this conscient encoding will create a very high energy consumption, a very high mental energy consumption. And it's why the approach has to be step by step. At the beginning, when you will start doing, for example, stitches in laparoscopy, you need to see what is a needle holder. You need to be able to do both hand coordination. Then you will be able to manipulate the needle, then to make the loop, and so and so. So the first period of encoding before the skill get automatic is something that creates a very high energy consumption. As opposite, once you get this storage, this information storage, there is no more or very few energy consumption with the automation of the process. And if we think about what can bring simulation training, is that when we have a very automatization process in our mind, there is definitely a decrease of vigilance because we know how to do, so we do the skill without thinking of what we are doing. And in this case, there can be a decrease of vigilance. It's why it's very interesting to use simulation for risk prevention to be sure that when there is this automatic process, introducing some affect, some perturbation, to be sure that the vigilance stays stable. And it's something that you can use with simulation to prevent risk. If we go on about the technical skills and the basics of education, what we know is that the fidelity and the technology that we will use to learn and to get an acquisition of a skill is not always, you don't always need the higher fidelity, the higher technology device to do that. And it has been shown by Agarwal more than 10 years ago now, that when we are dealing with novice, you can have a very high skill acquisition with a very low simulator, very low fidelity simulator. And as soon as you will move to very complex technology and very complex process, as we have seen with the wonderful talk for the ERCAT team, there is a need for higher fidelity simulator. But at the beginning, there is no need to have always the best things just to train the lower levels. So let's think about this cognitive principle is about learning curve. In fact, in learning curve, we all know that there is a learning curve for a simple process is not the same one as a long learning curve for a very complex process. And also when we are dealing with simulation program, especially if we are dealing about models for surgery, for pathology, we need before to be sure that the learning curve using the process is not 2 repetition or 5 repetition, but sometimes it can be 5, sometimes it can be 50. For example, when we are training students about doing a laparoscopic stitches, we know that we need 9 hours for them to be fixed, to have a fixed knowledge and an automatic process. So for the learning curve, each curriculum has its learning curve, and there is no definite learning curve, I think, for things. If we move to not skills training, but if we move to communication and what is called non-skill, non-technical skill, the best example about learning cycle, we can say learning process is a cobble process. It means that when you have an experimentation, you need to, in mind, create. When you will live a concrete experience, in mind, you need to think about your experience, then you need to concept it, then to do the experimentation. And there is this cycle like that it means that in fact, in each time we are doing something, we need to have a feedback and to think about our feedback and to try it again. And this is the most important model. So just to summarize what I speak about. So for the cognitive principle we can say in simulation, so definitely there is a need of curriculum alignment in all the process, in all the curriculum. You have to be worried about the mental load, and we always think that the mental load for students is not so big when they just start in their experience for novice, but it's wrong. They have a very huge mental load at the beginning of the situation, and we don't need to put too many objectives at the beginning. That going really step by step for the process. There is a need to reactivate the knowledge. And this is why simulation is so interesting, that we can reactivate the knowledge very regularly, going in a simulation center, and we don't have to wait the new patient with this process. It's especially interesting in pediatric surgery, where the recurrence of complex process is not so regular. We have to think about the emotional retention of the things and the reflective learning. So if I can summarize what this very basic cognitive principle for simulation, I think each curriculum has to be adapted and to be graduated and has to be mandatory, in my opinion, because if, especially in the beginning, if we ask the student to do things, they will do it, but they will also do something else. If there is a mandatory curriculum, they will be involved in it. And if there is a mandatory and an evaluation at the end, they will be efficient. And it has to be mandatory with faculty with them physically or faculty with them virtually. So maybe in the coming future, there will be metaverse, there will be exchange that we can have a faculty with video and with connection, but it has to be, in my opinion, controlled by faculty. It has to be a step-by-step process, definitely. And each step has to get its own evaluation. Using a skill, it has to be done at the beginning without clinical context. Then we can introduce the contextualization and the emotion. The debriefing has to be present in all steps. There is a need for recurrence. And as soon as possible, you have to ask your older students to be teacher for the younger one, because it will add them, it will help them to have a good memorization. So if we can summarize, we are definitely all thinking that simulation is a wonderful pedagogic tool for pediatric surgeons. It will be efficient to decrease initial and continued cognitive load for residents. It will introduce the reflective approach, and it will never replace the companionship and the work in the OR, but it will complete it with very good efficiency. Thank you so much.
Thank you very much, Jan, for your very nice lecture. And I ask to the audience, there is any question? Please.
I have a question.
Yes, Marco Dimitri. Marco Dimitri is a resident of the pediatric surgery of Bologna. Please, Marco.
Hi, Mr. Bru. Thank you for your presentation. I will ask you, what do you think about the education of the trainer? How should it be conducted?
I think the education by the trainer is very efficient if the curriculum and the limits are very well structured. You can ask a trainer to be a teacher if he has an exercise, very precise exercise, if he has also a very precise evaluation of the thing, and if you control what's going on. It's more efficient, we can say, than with an old teacher as I am, because there will be a friendship between students. This is very good. But what you need to do is to have a very strict control of the situation. So it's not complicated to ask a trainer to be a teacher. It's complicated to be sure that the trainer teacher will limit, we will be able to limit what is speaking about. So it has to be based on very good evaluation form for that.
Thank you.
Thank you, Jan. There is other question from the audience, please.
I have another question.
Edu Thomas is a resident of pediatric surgery of Bologna. Please, Edu.
So thank you for your presentation, Mr. Bro. I would like to ask about how to organize a simulation program for residents, because as a matter of fact, we know that residents are often overwhelmed with duties in the departments and in the surgical ward. So do you think we need to create a specific time during the week when they have to attend their duties regarding this simulation program?
This is the major topic, we can say, because as you precise, as soon as the resident starts to be in the department, they spend their time in the department. So It depends on the country. We can say in France now we have there is a legal obligation for the resident not to be in the department for at least half a day by week to have educational topics of pedagogic value and so on and so on. In my experience is that we initiate the system, the pedagogic program, before the residents start in the department. So we just catch the new resident 1 week before the start. So in France, it's at the end of the October, and we push them in the simulation center to discover everything. This is the first step. And as soon as they start to be in the department, we have create a mandatory program. It definitely depends of the willing of the dean of the faculty, of the chief of the department to allow the resident to go or not to go. But it's the problem. What I say is that if there is no constraint and if it's not mandatory, whatever you have a pelvic trainer in your department, at the beginning you will go 10 times and 5 times and 2 times, and it will be just be let in a place and nobody will go anymore. So the curriculum to work has to be fixed with obligation doing 5 hours per year, for example, and it has also to be fixed with the universities that say you need to go, there is an obligation for that. But it's complicated. This is the most complicated thing.
Okay, thank you.
Maria Baez, welcome, please. Hello, Maria.
Hello.
It's a pleasure to have Maria in this meeting.
Hello, Maria.
Hello. Can you listen to me? Because I am in Frankfurt Airport. I'm sorry.
We listen very well.
Okay, thank you. I just want to, to tell the residents that it is possible to start simulation and to include it in the curriculum. And I think that, especially if he is your resident, Mario, you will have the willing to do that with very low cost models and organized assessment. You don't have to think that simulation is a place where you need a fancy place with fancy models. It has to be the content.
Buongiorno. Perché non sento, secondo lei?
Alberti, stacca l'audio.
Okay. Is it me okay? I am okay?
Yes, we listen very well.
Because I am on the way to Ircat Barretos in Brazil, coming from Africa. So that's why I'm here. And so I want to congratulate you, Mario, for this wonderful meeting. I have listened to Silvana and now to Dr. What's your name, Doctor? I have your last. Okay.
Jean Breo. We met many times in many
I know.
years ago in Barcelona, I think.
I was not aware of your first name. I didn't want to say your last name. And so that's my message. And anything I can share with you, simple things. We have developed very low cost, but effective simulation, especially for the essential skills, because never the essential skills need to be underestimated. So anything I can share, we have been working a lot with telesimulation in pandemia, and we have published that it is effective. So the residents are always ready for that. You can imagine. So I think that's my message. And thank you for
thank you, Marcella,
for inviting me to listen to the conference. It is very nice.
Where go you, Marcella?
Where I'm going?
When go? You are the when go?
My plane?
Yes.
At 9 p.m. So I have time. That's why I'm very happy to be here too. So I'm otherwise in the hospital. I never find that,
Thank you very much.
Thank you.
Is any question, other question from the audience? No. Please, now I invited Edu Thomas to speak about from the advanced teaching to advanced simulation models in pediatric surgery. I say before that Edu Thomas is a resident of pediatric surgery of Bologna University. Please, Edu.
Thank you, Professor Lima. I'm going to share my screen. So,
yes, we see your share, please.
Okay, perfect. Good morning, everyone. And I would like to thank Professor Lima for giving me the opportunity to speak to you about advanced teaching and advanced simulation models in pediatric surgery. So as we all know, the COVID-19 pandemic, which struck the globe in 2019, compelled governments worldwide to enforce laws which severely limited the personal freedom. And clinical and medical teaching activities also were affected with an important interruption in frontal lectures, internships, and master courses. Therefore, the university and surgical departments, which are responsible for the training of young residents and young surgeons, were also compelled to rely on systems such as e-learning and web streaming platforms. In this scenario, the concepts of virtual reality and augmented reality provided us a solution to allow the students to continue with their internships and the young surgeons to go on with their training. And for instance, thanks to virtual reality headsets, we were able to allow students to participate in the clinical and surgical daily activities from distance, such as scrubbing or a varicocele procedure, and they can feel their surroundings as if they were in the theater with us. And talking about augmented reality, we used it to apply the concept of telementoring, and we can see a young surgeon, a young resident approaching a procedure for the first time, and he can receive visual aid from an experienced surgeon elsewhere. And the same principle is applied on this exercise on an anorexia malformation simulator. So actually, that of the training of young surgeons and residents is a big issue in Italy, as not only due to the lack of centralization of rare diseases, but also because of the birth rates in Europe, which have been drastically falling. And we can see the data from the European Academy of Statistics and the National Institute of Statistics, which show a persistent trend towards a decline in the birth throughout the last decade. And that's why we had to find a solution, and we decided to organize a simulation center. And you can see this is our simulation center at our department in Bologna, where we have several laparoscopic box trainers on which residents can train with on laparoscopic appendectomies and cholecystectomies. We also have digestive and urinary endoscopic simulators, which allows us to practice with cysto-ureteroscopies and not only diagnostic procedure, but also operative procedures such as the submucosal injection of bulking agents. And we see a couple of residents practicing on gastric endoscopic biopsies here. We also have simulators for anorexia malformations and Hirschsprung disease, and also congenital diaphragmatic hernia. And we can see in the picture a young surgeon who came to visit our center, practicing on one of these. These products was actually the result of a thesis of one of our students, and it shows how a rudimental home-built laparoscopic box trainer can yield the same results as an expensive box trainer. We also have an esophageal atresia simulator, and we can see a young resident practicing with the ligation and transection of the tracheoesophageal fistula. So we also know that advances in medical 3D printing technology have made tremendous contributions to the field of healthcare. And for instance, bioprinting and tissue engineering is one of these. We also have bioink, which is the material used to produce engineered live tissue using 3D printing technology. It can be composed only of cells, but in most cases, an additional carrier material that envelopes the cells is also added. And this is usually a biopolymer gel, which acts as a molecular scaffold, and cells attached to this gel, and this enables them to spread, to grow and proliferate. You can see this bioink has been applied to print a biologic heart on an ear also. And we can see that in this article, we can see they devised an endoscopic 3D printer, which can be used not only to print during endoscopic procedures, but also to create a molecular scaffold in laparoscopic procedures on which they can then deposit engineered cells, and which can then proliferate and cellularize the scaffold. Not only bioprinting, but also custom-made prosthetics. The point with children is that as they grow, they actually outgrow their prostheses, and they require, therefore, expensive repairs. So prosthesis manufacturers can take the advantage of 3D printing to mitigate the high financial barriers of this type of activity. We also have prostheses for amputees as well. So 3D printed anatomical models from patient scan data are becoming increasingly useful tools in today's practice of personalized precision medicine, and healthcare professionals, hospitals, and research organizations across the globe are using 3D printed anatomical models as reference tools for preoperative planning and intraoperative solutions. And we can also see physicians using these patient-specific surgical models to explain the procedure beforehand, improving the patient's consent and lowering anxiety and stress connected to the procedure. At last, we have to speak of surgical models. We have 3D printing that can allow us to prepare surgical models, such as an heart that can be used for heart surgeons to practice, and vascular structures that can be used in endovascular surgery. At our center, we recently acquired a 3D printer, thanks to which we obtained a segmentation from a CT scan of a patient with a dilation of the urinary tract, and therefore we use that to print a model of a kidney and a ureter with a UPJ obstruction, and you can see the pictures here. And therefore, we're going to use these to practice laparoscopic bioplasty among residents and young surgeons. Thank you for the opportunity.
Thank you, Edu, for your nice presentation. I ask the audience if I have a question for Thomas, Dr. Thomas. Please, we have a question about this lecture. Okay, thank you very much.
Really?
Please. There is a question? I don't see. Okay. Now, Marco Dimitri, that is a resident of pediatric surgery of Bologna, speak about the telemedicine application in pediatric surgery. Please, Marco.
Yes, 1 second. Okay. Okay, good afternoon, everyone, and thank you, Professor Lima, for the presentation. The term telemedicine was coined by Thomas Bird in 1916 from Latin medicus and Greek tele. Just in 1920, someone was thinking about telemedicine. You can see in the picture James Beck, that is a doctor, an inventor, that just in 1920 said the busy doctor will not be able to visit his patients as he does now. He takes too much time and he can only at best see a limited number today. So in 1920, he was already speaking of telemedicine. Before he invented this instrument that you can see, that is called teledactyl, which is a telemedicine platform that would allow doctors to examine, diagnose, and treat patients from a distance with the robotic arms and an adaptive feedback system, and by means of television screen. So it's something like our new robots daily used in our clinical practice, but in 1920. It's really incredible. Over the year, the advancement of the internet greatly facilitated the adoption of telemedicine across the globe, as it made transmitting medical data and communicating using live video infinitely easier. Internet promised to transfer data files and connect the doctor with their remote patients more easily. So COVID-19 pandemic was crucial for the development of telemedicine because the unnecessary contacts of medical professionals and patients were vital during the COVID-19 crisis to mitigate the rapid progression of the virus that greatly affected many individuals. So in our department, we use the Cytohome by Cytocare. This is an incredible device that replicates the doctor's physical examination, regardless of where your patient or your clinician is. The Cyto device includes a camera, a thermometer, an otoscope, a stethoscope, a tone depressor, adapters. By this device, it's possible to make a complete clinical exam, including evaluation of the lungs, heart, hair, mouth, and skin. Cytohome is connected through a mobile app installed on the patient's smartphone and clinician's dashboard for conducting live or remote physical examination, reviewing the exam data, and communicating with patients. In our department, we use this device for the postoperative follow-up in anorectal and thoracic surgery, or for who need advanced medication, postoperative for advanced medication and all. So it's important, especially for who live far from our hospital or in other country. When we enroll the patients for telemedicine follow-up, we follow this scheme. First of all, education. So we create an account with the patient's data, and we make the first trial exam with the caregiver. So as you can see in this video, we fill this form with the patient's data, and after we have saved as an email arrives to the parents of the patients with the account data. Parents downloading the app can access to their personal account, and after that, we explain to parents how to use the device and how to connect it with the smartphone app. So patients can easily record and send us the requested exam. This is the clinical dashboard that where we can see the recorded data and where we can comment the exam. Finally, there is the clinical report. So we can see the exam sent us and comment it. Now I'm showing you some application of this device. In this case, we followed a patient who needed the long-term medication after endoscopic piloneal sinus treatment. And as you can see, the parents show the wound without any secretion, also it's compressed, permitting us to monitor the wound until healing, avoiding patients to come every week in our department for control, spending time and losing days of school. This is another patient from Peru with an anorectal malformation, underwent a Bianchi surgical procedure. We're following these patients for the calibration of the neoanum through this device, so we can monitor the diameter of the agar used, if there is any difficulty to introduce it, and if there are blood traces after calibration. In this other video, we followed through lung examination. A patient underwent to an nasal repair for pectus excavatum. As you can see, the device suggests to patients the exact position where to place the stethoscope. So, concluding, telemedicine, especially if used with device like this one, seems to be an extraordinary resource for doctors, allowing to follow the baby, avoiding stress of hospital medication, losing days of school. Telemedicine's greatest strength lies in its ability to overcome the barriers of distance and time to reach medically unserved population. So as technology continues to improve and decrease in cost, telemedicine will improve access to care, emergency response. It will also increase in communication between families and medical professionals caring for their children, even in general pediatrics in community-based practice. So these I think that are the best positive thing about telemedicine. Thank you.
Thank you, Marco, for the presentation, that we see what is the potential of telemedicine in pediatric surgery. I ask to the audience if I have a question for you. Jean, please.
Yes, thank you so much for this talk, which was very interesting. And I agree with you, because I think telemedicine is now something which is coming in global mentality, and we need definitely to have a structuration, because if we all see in our experience that more and more patients send us by email a picture of the wound, a picture of aspect after hypospadia surgery, and there is this way of communication with the use of pictures, the use of WhatsApp, for example, of video, is ongoing, and people are used to use that for their coming life and their normal life. So I think it has to be structured using application as the one you show us, because it will be definitely the future of the way to follow people, I think. So thank you so much. It was very interesting, really.
Thank you.
Other question from the audience, please. Okay. Now I invited Jean with the second presentation specify of simulation program for skill training in pediatric minimally invasive surgery. Please, John.
Thank you. So
yes, we see your laptop.
Okay, so me again, and again I will be back to the antiquity, because after the wonderful talk that has been presented with IRCAD, and then with what is your experience in Bologna, I'm afraid I will speak about all things, but I will just try to give you my ideas and my thinking after 15 years of simulation in pediatric surgery, and what is the simplest way to do it with a very good pedagogic congruence. So we all know that a pediatric surgeon is a surgeon which is a little, we can say, à part in French, because he has to deal with a very different size of patient, to the smallest to the biggest patient during the same day. And he has to deal with very, very large catalog of procedure, and with very low occurrence of this procedure. So Hamilton said that in 2011, pediatric surgeons possess unique skills compared with general surgeons that relate to the technical challenge they routinely face, reinforcing the need of simulation, of course. So the second thing is not definitely about skill training, but for me, it's not possible to disconnect skill training than to communication training and to communication with teams. So a pediatric surgeon has to deal with a very high accuracy and efficiency in communication, because he will not only speak with the child, he will also speak with the parents, and with internet and all the big data system. Now parents know many things or believe they know many things. So it's definitely it's a part of the work of a pediatric surgeon to be aware of these topics. And the last thing is that as a teacher, we can say, we have to deal with the willing of a surgical resident just to do simulation and just to do so with skills and to be in the OR, and not to forget that our life as a surgeon is communication, consultation, and follow-up, and skill, but not only skills. So all know that the resident don't get so much time to train, and all know that there is we are not allowed anymore, and this is a very good thing to train on patients. And all know that the complex malformation decrease dramatically in Europe. So there is a need for simulation, of course. So if we go very quickly about the training goals in minimal invasive surgery in pediatric surgery, I think there is the minimal invasive surgery specificity. Then we can speak about basic skills, advanced skills, and specific procedure. And what about the first thing, which is the pediatric specificity? My opinion is that we can't disconnect training in pediatric surgery for skills, that what happened in the OR. And we all know that a surgeon, if he has not the good light, not the good installation, will not be able to do a very good surgery, especially in missed surgery. And all of us have had the experience to do minimal invasive surgery on a very small baby, which is 4, 5, 3 kilos. And you have maybe 3, 4, 5 kilos of light, cautery, gas, camera, and all what I call the spaghetti syndrome, we can say, where you have everything coming around the baby and you don't see anymore where is the baby according to the installation and the installation of the patient and all the different devices you get. So first step maybe in pediatric surgery, minimal invasive surgery, is to be able to know how you will create your installation for the patient. And this has to be trained definitely. If you don't train that, you can be a very good surgeon, but if it's a mess around the baby, it will not work at all. According to the basic skills, I think a pediatric surgeon is like a normal surgeon or an adult surgeon. So we can train, and it's really easy to train basic skill with the most famous topics as FLS skills with plot transfer and all the exercise you know about the FLS. But what you have to be worried about is to prevent this kind of situation. So I just want you to show this very small video. This is we can say a pelvic trainer FLS. But what is interesting to see is that all the elements are moving. And maybe the very big difference between a pediatric surgeon and a general surgeon is that the movement has to be very smooth and on a very small place. And my advice is to focus when you are dealing with basic skill for pediatric surgeon, to focus on the precision of the movement and to find solution for your pelvic trainer to be able to move if the student does too big manipulation. So in my simulation center, nothing is fixed. And as soon as the pelvic trainer is moving, I stop the exercise to say, okay, start again, and try to have movement very more slow and more smooth. The second aspect for basic skill is to do, as I said before, a step-by-step process and to deal with the size of the working space. And it's why I put this picture of the FLS that you all know and the PLS, which is a pediatric laparoscopic simulator that you all know also, that has been developed in George Hazy teams, and who create the condition of neonatal laparoscopic surgery. And our deal for us as a pediatric surgeon is to be able to switch from big size to small size and to be able to work in small size. So here you see, so this is the FLS you all know, and this is the PLS. For the ones that don't know this system, you see it's a 3 mm instrument, and the need for movement is to be very more slow and more smooth because this working space is very, very small. So what you can do to work about space is you can do very small, very simple thing. You can imagine that you get a FLS pelvic trainer, standard FLS pelvic trainer, and you just put some boxes, or you can also use the box for the stitches we get in the OR. You can put some boxes just to reduce the volume. Also, what you can do is to decrease the size of the screen using a sheet of paper to make just a mask, and for the resident to work only on the small place where he can see the screen, in fact. So, according to the advanced skill, my experience as a pediatric surgeon is to think that when you are able to do suturing with 3 mm instrument with very small stitches in a PLS pelvic trainer or in a very small, very tiny space, you are able to do more or less all the movement you need to do for surgery. Definitely suturing is the most complicated things to do. Suturing in small space is the most complicated things to do in pediatric surgery. So we have now many specific models for many specific procedure using, as you assured us before, and 3D printing, animal tissue, and all these models have a different level of fidelity and of technicity. And what is very interesting, I think, is that with all these models, now we have in pediatric surgery thousands of ways to train in esophageal atresia, pyeloplasty, as you present, Hirschsprung disease, and so on. So the most important thing is to use this model, which are sometimes not so expensive, sometimes very expensive, to use this model after a training on very simple basic skills, and not to introduce this model when a resident is not able to do stitches, because if no, he will spend this model for nothing, and he will don't feel the interest of the model. So there is, in all this amount of wonderful models that have been created, there is definitely, like we can say, a catalog, and this catalog has to be chosen according to the level of the student and also the pedagogic objective for the student. There have been a very recent meta-analysis about these models. So it was published a few months ago, and in all the literature, Judson finds there was 38 simulation models described, and thinking about the validity of the models. And in all of those, 22 were valid, and 70% were inanimated. So it means that the technology now, which is very interesting, I think is not yet present in simulation, and maybe is very efficient, but we can still train our resident without very high technology models for pediatric surgery. So this is just to, all the PLS. I will move very quickly around that. For esophageal atresia, you can move to 3D printing, as you have presented, to animal or hybrid models using rib cage, which is in 3D printing, and putting some rabbit esophagus to very, very low cost system I made many years ago with just plastic tube. We have many other things. You have things for novice, things for new procedures, things for specific procedure. This is you all know that model now. But what I can say, just to summarize, because first problem for MIS in pediatric surgery is to deal with the two major difficulties: the size and the values of procedure. According to the size, I think it is very important to deal with very small space. And so everything you can do to reduce pelvic trainer space and using 3 mm instrument is efficient. This basic skill has to have a standardized learning curve. Then you will move to the second step to use specific model for process on validated model, because when you create something in your own place, you need to validate your model to be sure it's efficient enough, because there is a risk to have thousands of models of esophageal atresia, thousands of models of lobectomy, and so, but the need for validation is a really specific pedagogic process to validate the model. Then for me, in my mind, the third step is to work with the installation, preparation of the patient, ergonomy of the surgeon. It's a part of the MIS process. And for that, you can create some scenario in a virtual OR using a small baby in plastic and putting all the device that you will use for the surgery. And I think our residents need to know that, because it's very important to have good installation, good ergonomy in this kind of surgery. But I will not go to the discussion about should we use low fidelity, high fidelity, low cost, high cost technologic model, because this is something which is a very complicated discussion. I think you need to use the model you are used with, and the one you get the validation for that, and you get the evaluation for that. So about the technical skill curriculum, we need to have ongoing evaluation of performance. You need to have the criteria for validation of the skill. And if we move to a very technical aspect, when I'm doing training sessions for residents, I use very short period training, less than 2 or 3 hours. I use 2 trainers for 1 simulator, and they move each 15 to 20 minutes. And I use teachers, so faculty. If the best thing is to have 1 instructor for trainer, and the validation will be adapted definitely to learning curve with the repetition of the validation. And also we need to have recurrences of the training is 3 or 6 months to keep the memorization. So simulation is good for pediatric surgery and pediatric laparoscopy, of course. It's very benefit for novice, and it will allow to have discrimination for novice and expert, and also it will allow us to do training for beginning, and also to train for new process, new complex process. For instance, because there is no more or less, we can say, baby with malformation, with complex malformation. So in Europe, there is definitely a very huge need to train in simulation for complex pathology. The curriculum has to be gradual and mandatory, but I spoke about before. And also, whatever we're speaking about MIS, we need to train residents with communication, TWIM training, installation of patient, and so on and so on. So, and I know that there are many curriculum now, national, international, many courses for one pathology, and this system has to be increased by years. Thank you so much.
Thank you, Jean. Very nice presentation, very interesting. I ask to the audience if have a question for you. Yes. Oh, okay. Edu. please.
Thank you, Mr. Bro, for your presentation. I have a question about animal models, and I guess you use the porcine model, and I wonder at what points of the curriculum do you include exercises on the animal model? And I would like to ask an advice on how to, I don't know, in Italy, it's quite difficult to have peaks on which to practice. So do you have any advice on how to provide material?
Mm-hmm. So no, I don't have any. I'm sorry, I don't have any solution for that, because it's also very complicated in France, and the European legislation has been really more complicated. But I think animals models. The fact is that the level, we can say, of fidelity and of reality of animal models is very high. This is definitely sure. So, in my opinion, animals models have to be used on a very short period. You need to have a resident or a surgeon, which is definitely very efficient in simulation, in low, we can say in low fidelity simulation. So it's suturing, it's using PLS material, doing having a high level of being able to suture in very small space. Then it can do one time, it can go one time, IRCAD or I don't know, Bologna or somewhere, just to do one training. But now with 3D printing, with all the ability we get to have a very efficient curriculum for basic skills, the animal models has to be just to get an idea of the reality. Is the last level, you know. So there is no need to have thousands of laboratory with animals, because it costs a lot of money. It's very complicated to in fact, in pediatric surgery, the thing is a little different that in adult surgery. An adult surgeon will be specialist in hepatic surgery, and we will do 50 hepatectomy by year, for example. In pediatric surgery, what we need to be able to be efficient for everything. So in MIS, we need to be able to do suturing, dissection, and so in very small space, and to have this background. And after that, the simulation will help you to know, oh, an esophageal atresia, the difficulty is at this level. In we can say in lobectomy, the difficulty is at this level. For the pelvic junction, the difficulty is the time to cut the ureter, to cut the pelvic junction. So through 3D model printing, we can create 3D model printing, focus on this very small difficulty. But we don't need to have a very high recurrence of one systematic pathology. And animal models will give you just one time the idea, okay, for a pelvic junction, I need to do my installation like that and not like that. But you don't need to use 10, 20, 50 repetitions on the animal. So I think it's not a problem in my opinion. I don't know if I answered to your question. But...
Yeah, thank you for the reply.
Thank you very much, Jean. And now Tommaso Gargano asked a question, please.
Okay.
Michela,
I have
yes,
a question. Okay, so I have a question for you regarding the dry lab. According to you, which are the limits of only a dry lab? We have to pass mandatorily to an animal model, or we have solution also only in the dry lab? I mean, I think yes, surely tutoring is one of the most difficult skills to acquire, but I think it's also quite easy to reproduce in a simulation lab. Okay, I can take a little box, put 2 gauzes and try to suture. While I think it's very difficult to recreate, for example, blunt dissection or to have a real real consciousness of the tissue in a dry lab. Because we have wonderful models with red tubes for arteries, blue tubes for veins. Okay, everything seems easy, but which are, according to you, the limits of a dry lab, if there are limits?
Okay, thank you for your answer. Your question. The fact is that animal is a wonderful model. This is definitely sure, but the problem is that we don't get any more so much lab with animals, and it's very complicated to work on it for all the residents. So my opinion, I agree with you, is that we can do most of the work on a dry lab, and then finish on an animal exercise or something like that. But we can do most of the thing on a dry lab. The element, what is very important is that the model you use has to get validation. And this is the most complicated thing to get. Because, for example, many 15 years ago, I create a model for, I show you for esophageal atresia, just with very plastic tubes. And this model was not realistic at all, but it allows the resident to know the different steps of the process and to focus on what was the difficulty for ligation of the fistula, for example. And on this topic, this model had a validation. So the fact is that you get really a catalog, and you need to choose the one you want for according to your objective, pedagogic objective. And for the risk, and my opinion is, I have seen many models created in 3D printing, for example, and this model wanted to go very, very far on a level of reality. But is it really useful? That's a question we always have to ask us. Is it very useful to have a degree of reality which is massive? And my opinion is, according to now what we can use with 3D vision and what has been presented by the ERCAT, for example, maybe we will move directly to this step, and the 3D printer will be very interesting to focus on specific part of the model, but not all, in fact.
Thank you very much.
Resolve the question from the audience. Okay. Thank you very much.
Professor?
Jean? Oh, yes.
Professor,
Oh.
Maria Bailes, a question.
Oh, please. Maria. Marcela.
I'm
Marcela?
sorry.
Okay.
Yeah,
okay.
yeah, I'm here. I was muted because I am in the airport. But I just wanted to add to Jen's comment, because I completely agree with him. I have been to different courses where people are put to learn in an anesthetist peak, and they don't really know the basic skills. So I think the animal model has to be definitely just done when all the essentials are trained in dry models and very focused on what they are going to do in the model. For example, steps of an incision, steps of a nephrectomy, whatever. But when they already know how to suture, how to dissect, how to use both hands, how to use the electrosurgery. Otherwise, that's not good. It will not happen in the future. I think it's disappearing. But of course, the fidelity of the tissue, as you have said, is better. So some things that we do is in hybrid models. In some trainers, we use live tissue in the trainer, and you can get that live tissue as an intermediate, as a bridge to go from dry models to, if you need at last, an animal model under anesthesia. And I think I completely agree with him that everything needs to be validated, and there always has to be an expert behind the model. it's not a report that people developing the models had nothing to do about the procedure. And that's the important thing in pediatric surgery. That's what I think.
Thank you, Marcella, for your comment. Thank you very much. And any question? Okay. And now,
Rosalima?
oh yes. Oh,
Hi.
It's a pleasure to see you.
Hello,
Please.
Katharina from Switzerland. Thanks for your talk and thanks for the invitation. I would like to know if you have in France or maybe in Italy also some kind of curriculum where you can introduce nationally wide to get a pediatric surgeon, and if you're also tested by that when you do the specification, the exam. Nobody was asking me for doing any showing any laparoscopic skills when I applied for the exam, but I think that might be the future. You talked about that we have to have a few lessons, a few hours per week as an obligation. I think that's very important too. But I think also that we have to increase the motivation for the young doctors to get the skills.
Thank you for your comment and question. Yeah, yes, in France we have introduced a curriculum now. It's the 5th year of this curriculum running now, and this curriculum is a national mandatory curriculum. It's based on 2 days of simulation for all the residents in the country. So it's 2 days yearly, and the curriculum is based on the 3 topics of our job. So there is skill training in low-cost, minimal invasive models as pelvic trainer, and also we get models for esophageal atresia, for pyloric stenosis, for hernia, and pyeloplastic. There is topics about communication. So we do scenarios with actors or students who do the actors, resident, and also psychologists to deal with all the dimension of the communication. And we have 15 scenarios from very simple situation as the announcement of an appendicitis for a child to very complicated situation of prenatal diagnosis, for example, for laparoschisis, or very complication, post-operative complication. And there is a 3rd step, which is, we can say, an in situ simulation. So the scenario is that the resident entrance is the OR, there is a baby ready to have ectopic testis surgery with laparoscopy, and there is many mistakes in the process. We don't get the medical report, the parameter of inflation are bad, and so on, so and so. And the resident has to move through the scenario and to check all the elements. So this scenario, this curriculum now is mandatory, it's regular. This is the 5th year of working in France, and it's working definitely well, with less than 10% or 15% of residents missing. But we don't use yet for validation. I think the next step will be to use it for validation. In France, we have a very big process for students, medical students, to get validation through ECOS and through simulation. And I think in the coming years, we will move through that also for residents in pediatric surgery, but it's not yet used for validation, but we are working on it.
Very interesting, thanks.
Thank you, Jean, for your answer. And from the Switzerland, we go in the Brazil. Please, have a question from?
Yes, Marcelo from Brazil.
Yes,
hi.
Please.
Hi, Dr. Emma. Thank you so much, Dr. Bro, for your talk. I agree with many things you said, and I wanted to ask you, how do you objectively measure, for in the low fidelity models that the trainee is he's able to move from one step to another. As you said, you know, we need to go step by step, progressively in our training. And so how do you objectively measure, you know, the acquisition of skills? Because it might be too subjective. I don't know.
So
thank you.
You're welcome. Thank you for your question. So it depends of the skill, but I made mix of I create an evaluation form for each skill, and on this evaluation forms we get some metrics, we get some yes and no. We can say like a checklist, yes, to check, for example, the position of the needle holder, the way to make the loop, for example, it's yes and no. And also I use OSATS scoring. I don't know if you know this OSATS scoring. And for example, for suturing, now we have in France, we have a diploma for laparoscopic in MIS, and we evaluate our residents for the technical skill on an OSATS scoring, adapted for suturing. So it depends on the situation, but I try to have for one step, one evaluation each time.
Okay, thank you very much.
Thank you very much, Jean. And thank you very much, Marcelo. Other questions from the audience? No. And now, last but not least, Professor Mario Messina is a good friend of mine. Mario Messina is the pediatric surgeon of Siena University and is the president of the board of director of the postgraduate school in Italy. And the topic is project for the advanced teaching and simulation program for postgraduate school in pediatric surgery in Italy. Please, Mario, we see your laptop if you want to start.
Okay, grazie Mario. Good afternoon, everyone. Thanks to Mario for this opportunity. I will expose my presentation in Italian. Ok. La formazione in chirurgia pediatrica sta conoscendo un'evoluzione molto rapida che è legata in parte alle richieste formative crescenti degli studenti, che impongono quindi una didattica estremamente dinamica, ed in parte all'evoluzione tecnologica, informatica e robotica, che ha coinvolto la nostra specialità. È noto come la formazione debba includere queste 4 tappe formative che vedete in diapositiva. Il loro rigoroso rispetto in senso pedagogico dovrebbe consentire al futuro chirurgo pediatra di realizzare l'atto terapeutico chirurgico più indicato nella specifica situazione clinica. E questo processo attualmente come si realizza? Mediante l'integrazione di studenti specializzanti nelle equipe chirurgiche universitarie, secondo un processo osmotico progressivo legato al contatto con i chirurghi già formati e mediante la consultazione di testi, di briefing di reparto, di corsi, di congressi e di attività di sala operatoria. E, va bene, in realtà però questa organizzazione didattica offre dei punti critici che sono legati alla riduzione della natalità, all'incremento del numero degli specialisti che abbiamo ogni anno, il problema anche della responsabilità medico-legale e per finire una non idonea distribuzione dei ricoveri. Infatti, va bene, questo è, va bene, diciamo, è un'inchiesta di Federe Specializzanti in cui sono stati presi i 4 interventi più frequenti in chirurgia pediatrica: l'appendicite, l'ernia inguinale, il testicolo non palpabile e la fimosi. Bene, voi potete vedere come ancora in un reparto di chirurgia pediatrica quant'è la percentuale che viene effettuato questo intervento. Quindi veramente c'è ancora molto da lavorare. E in più la cosa che ha colpito molto è che parlando con gli specializzanti, facendo questo, come potrei dire, questo a livello nazionale, che cosa è venuto fuori? È venuto fuori che l'82% degli specializzanti dice che non accede ai fondi che sono destinati a loro, che il 68% ritiene di avere delle responsabilità non previste per il ruolo che c'ha. E ancora, vedete, l'80% è insoddisfatto per la didattica, il 76% ritiene che la preparazione è insufficiente e il 78% non si sente adeguatamente formato. Questa, è stato quindi un campione piccolo, anche se piccolo, di 480 nell'ambito del territorio nazionale per tutte le specialità. Va bene? Allora, da questa quindi indagine preliminare, che cosa è venuto fuori? È venuto fuori che il rapporto tra l'aspetto teorico e quello pratico è più rilevante privilegiare il secondo, quindi l'aspetto pratico della formazione. La formazione pratica deve avvalersi di maggiore partecipazione alle procedure chirurgiche, integrata da corsi monotematici, e in più, per quanto si attiene ai mezzi didattici, particolare attenzione deve essere fatto allo scambio culturale tra differenti centri e in più la necessità di realizzare centri di simulazione virtuale, come ora poi vi farò vedere. Quindi largo uso, va bene? Quindi largo uso di tutti i mezzi didattici prevalenti, quelli pratici, e in più con modelli chirurgici. Ad esempio, poco fa si parlava di modelli animali. Io penso che questi andranno a non essere più usati, ma quindi incremento dell'interesse della realtà virtuale e dei centri di simulazione. Ok, quindi allora, va bene, dalla teoria alle immagini ai filmati, e-learning, e-teaching, addestramento, centri di simulazione, realtà virtuale e, va bene, centri di simulazione virtuale e sala operatoria. Qui, va bene, potete vedere alcune simulazioni che ci sono nel nostro centro a Siena, in cui gli specializzanti possono esercitarsi. Allora, ora il professor Lima mi ha chiesto una cosa molto difficile che ancora non è presente in Italia, e cioè un protocollo, va bene, per le scuole di specializzazione, va bene, che tenga conto delle nuove tecnologie, ovvio. E allora vediamo se riesco a dirvi qualche cosa di interessante. Innanzitutto, che cosa abbiamo in Italia? Perché Jean Brod ha fatto vedere come in Francia sono già un pochino forse più avanti di noi, ma noi possiamo recuperare un po'. Allora, cosa abbiamo in Italia? Finalmente in Italia abbiamo il syllabus nazionale per le scuole di specializzazione in chirurgia pediatrica, che è stato fatto 2 anni fa, di cui io come rappresentante diciamo della chirurgia pediatrica ho partecipato. Quindi abbiamo un syllabus italiano. Questo è un dato di fatto che hanno tutte le scuole di specializzazione in Italia e quindi può essere applicato. Secondo, dobbiamo partire da un concetto fondamentale che è di legge, e cioè requisiti specifici assistenziali. Nella chirurgia pediatrica, quindi una scuola di specializzazione, lo specializzante per poter avere, va bene, il certificato di specialista, durante i 5 anni deve effettuare 400 interventi, di cui 50 di alta chirurgia, 100 di media chirurgia, 250 di piccola chirurgia. Ma la cosa importante che dovete sapere, ecco dove era il concetto ora poi della realtà virtuale, della formazione, quindi della formazione che viene dopo. Il volume minimo complessivo per la rete, per avere uno specializzato, sono 2000 interventi. E il volume minimo dell'attività assistenziale annuale per l'attività formativa della scuola è 4000 interventi. Questa è legge, quindi fino a quando non viene cambiata deve essere applicata. Andiamo avanti. Finalmente, dico finalmente, va bene? Nel luglio 2022 il Ministero della Salute ha diciamo, dato delle linee di indirizzo sullo sviluppo della simulazione in sanità in Italia. Sono solamente delle linee di indirizzo, un tavolo tecnico che è durato 3 mesi. Però noi abbiamo diciamo ancora una carenza, che è quella che la simulazione in Italia, parlo, viene fatta senza protocolli standard nazionali, legata a un piano curriculare delle competenze, non tanto, ripeto, per uniformare l'aspetto, scusate, scenare attività, rispondi tu Rossella, scusate, esercitazione, quanto per creare delle griglie di valutazione e i relativi indicatori di performance con esplicito criterio di validazione. Quindi questo ancora non ce l'abbiamo. Come? Va bene, rispetto alla quasi totalità dei paesi, va bene, dei paesi, l'Italia non ha l'obbligo di sostenere esami secondo il modello OSCE, purtroppo devo dire in questo momento. Questo già, se noi ci potessimo uniformare, sarebbe il primo passo per formalizzare una denominazione comune di validazione delle competenze, ad esempio manuali, gestuali e procedurali degli allievi. E allora, dal mio punto di vista, oggi non è possibile trascorrere troppo tempo in sala operatoria con un chirurgo giovane, poco preparato e che non conosce le gestualità di base. Quindi è fondamentale che le competenze vengono acquisite al di fuori della sala operatoria, prima di entrare in sala operatoria. Va bene? E quindi è importante, essenziale, simulare semplici gesti chirurgici come emostasi, sutura, posizionamento di una clip e non meno importante preparare il chirurgo adeguatamente l'intervento con la realtà virtuale. Allora, ecco 2 parole sulla realtà virtuale. Che cos'è? Lo sappiamo tutti, è una tecnologia, non parlo della realtà aumentata che ha parlato molto bene, Silvana Parretta, quindi non sto qui a parlare della realtà virtuale, della aumentata. La realtà virtuale è una tecnologia simulata, come sapete. Si basa su un ambiente tridimensionale, è realizzata al computer, il quale può essere esplorato dall'utente usando appositi dispositivi, visore, auricolare, guante, controller, eccetera. E la cosa importante è che la realtà virtuale, che nasce dalla combinazione di software e dispositivi hardware, insieme permettono di replicare uno spazio virtuale all'interno del quale l'utente può muoversi liberamente, come se si trattasse dell'ambiente reale. Ok, e allora qual è il ruolo della realtà virtuale? In ambito medico, essa trova una collocazione importante nella preparazione di interventi chirurgici, particolarmente complessi, come ha fatto vedere alcuni relatori prima. Prima di mettere quindi mano al bisturi, un chirurgo può sfruttare tale tecnologia per esercitarsi su passaggi più articolati dell'intervento che dovrà effettuare. Allora, qual è lo stato dell'arte in questo momento che abbiamo in Italia? Abbiamo il syllabus, abbiamo le raccomandazioni del Ministero, abbiamo dei centri di simulazione. Ad esempio quello di Bologna è un ottimo centro di simulazione, a Siena abbiamo anche noi un centro di simulazione, ma c'è, va bene, non tutti hanno dei centri di simulazione e non tutti hanno una performance importante, purtroppo. E allora, va bene, per poter, va bene, fare un protocollo di formazione, un training, va bene, per quanto riguarda le scuole di specializzazione, questo deve essere fatto sulla graduale acquisizione di specifiche competenze, individuazione degli elementi chiave che sono necessari per avere un programma specifico di chirurgia pediatrica e infine una definizione di un percorso ben strutturato basato sulla progressiva acquisizione di specifiche competenze. Per cui, va bene, praticamente dal mio punto di vista dovrebbe essere fatto su 3 fasi. La prima fase, va bene, è una fase di apprendimento individuale preclinico che viene finalizzata a prendere confidenza con la tecnologia e l'assetto della sala operatoria. Una seconda fase con apprendimento tramite simulazione, in cui si passa da semplici esercizi a procedure molto più complicate, e la terza fase, la formazione clinica della sala operatoria. In conclusione, allora, ho voluto mettere questo bellissimo quadro di Picasso, va bene, in cui che cosa abbiamo bisogno? Necessità di risorse economiche, interazione tra università e industria sarebbe importante, adeguamento di mezzi didattici, impiego generoso della realtà virtuale, mobilità fra differenti centri, convenzione ad esempio tra sedi universitarie, ruolo delle società scientifiche. Vi ringrazio della vostra attenzione.
Thank you very much, Mario. Very nice presentation, and this is probably it's possible to start with the national program for the postgraduate school. I ask to the audience if you have a question for Professor Messina. Jean?
Yeah, it's not a question, but a comment, and I think what you propose is very interesting, and it should definitely work. In France, we had a discussion about the cost of such a program, and the idea was for the resident to come. If there was no funding for the program, it has to be simple for the residents. So rather to do a national course in one place or in 2 places in the country that asks the resident to take plane and to travel. We decide to do the same curriculum, but in 7 places in the country with a regional organization. So it allows to have very small groups of 5 to 10 residents with 1 to 4 faculty, and in most of cases, there was nothing to pay for the resident just to arrive to the simulation center. So this was a solution to decrease the price of such a program.
Oh, thank you for your comment.
Thank you, Jean. There is any question for Professor Messina? Okay, thank you very much, Mario. And I hope it's possible to start with this program in Italy, because I think it's very important for the resident and it's very important for the university. Now, Tommaso Gargano, following this afternoon with the formal part of the inauguration of the master and with the Harvard for the certificate and presentation of the new student. Please, Tommaso. Tommaso, we don't listen you.
Do you listen to me, Professor?
Yes, now,
okay.
Yes.
Thank you very much, Professor Lima. For me, is an honor.
Excuse me,
give,
Tommaso,
yes,
you listen to me?
Professor?
Okay. Tommaso is the director of the Master in Minimal Invasive Surgery and Robotic Surgery, and Michela Maffi, after, is the Scientific Secretary of the Master in Pediatric Urology. Please, Tommaso.
Thank you, Professor Lima. For me, it's a very pleasure to give today, this afternoon, the certificate of master degree in minimal invasive in the robotic pediatric surgery. In the slide, you can see the colleagues and the friends that have completed the previous master MIRPs in academic year 2020 and 2021. I give one moment I give you Alessandra Cazzuffi, Dottoressa Alessandra Cazzuffi. You do you see the persman, the official persman, Alessandra Cazzuffi? Very congratulations.
Thank you very much.
Chiara Grimaldi, very congratulations too for the completed master in MIRPS. Riccardo Guanà, compliments.
Grazie Tom.
Laura
Grazie.
Lombardi, congratulations to you. Dear friend Josué Massero, very congratulations.
Thank you very much.
For the results. Alessandro Pane, that I remember that was the winner of the best thesis, the prize of the best thesis. Very compliments, Alessandro.
Thank you, Thomas.
Marianna Scuglia, this is your performance for you. And the friend Anastasia Vareli from Greek, very compliments for you for the results. Okay. Now, Professor Lima?
Yes, Tommaso.
If
This
you
is
want, I give the teacher.
Yes, please. This book is the book
I
of the
give
Howard
you.
Master. Yes, please.
I don't, I don't listen. I don't listen.
Please, Tommaso, go. Tommaso?
A moment, because.
Tommaso?
Yes.
Okay, please, go.
Okay. It's usually, as always, we give a present for the attendance. This is our thing to the attendance that completed their training in Bologna. For Michele Corroppolo, this is your jacket.
Grazie.
You are okay. You are you are part of this school. Fabiana De Girolamo, for you. Valentina Montano, for you. Giovanni Parente, for you the jacket.
Thank you very much.
Noemi Pasqua.
Thank you.
Simone.
Thank you.
And Maria Pialarou from Cyprus.
Thank you very much.
Now, Professor Lima has always dedicated this book, this history book, the pictures of Magister, that it's a thing of this school. So I cite the dedicate of Professor Lima to Michele Corroppolo. A Michele Corroppolo, professionista serio in Italian language, serio e dedito al suo lavoro con la speranza che questo master sia per lui una rampa di lancio. Mario Lima.
Grazie, professore.
A Fabiana De Girolamo, con l'augurio che questa esperienza la arricchisca scientificamente e professionalmente, arricchendola attenta e dedizione e permettendogli di realizzare i suoi sogni. Mario Lima.
Grazie mille, grazie.
A Valentina Montano, valida chirurgo e donna forte, con l'augurio che tale traguardo sia uno dei tanti. Mario Lima.
Grazie mille, professore.
A Giovanni Parente, con auguri carissimi. Mario Lima.
Grazie, prof.
A Noemi Pasqua, persona retta professionalmente e, fra virgolette, curiosa di sapere scientifico, con i suoi interventi costanti ha mostrato tanta dedizione alla materia.
Grazie, prof. Grazie davvero.
A Simone Patanè, collega dedito, attento e preparato. Mario Lima.
Grazie, professore.
In English now, to Maria Chalarou, careful and scrupulous surgeon, she always showed great seriousness and desire to do. Mario Lima.
Thank you very much, professor.
Okay, now this is the book, the history of the sign of the school. So the attendants that completed yesterday their final thesis dissertation, and now the commission shows the prize of best thesis intitulated to the Pascal de la Gouzie to Noemi Pasqua. The criteria is the best thesis and the curriculum during the active part during the academic year. Thank you and congratulations, Noemi.
Thank you very much, professor. Thank you, really.
This is the prize for you.
Dear
Thanks.
Noemi, this prize for us is very important because it was dedicated a very old friend and a very fantastic surgeon that we know, Pascal de la Gouzie. It's an honor for you.
It's a pleasure. Thank you. Thank you very much.
Okay, let's proceed with the master. New attendance.
I present the new attendance, the attendance of this academic year, 2022-23. Dottoressa Lucia Corasaniti from Milan, Niguarda Hospital. Welcome in Bologna, virtually in Bologna.
Thank you so much.
Dottoressa Chiara Cordola, our resident in Sant'Orsola Hospital, Bologna. Dottor Marcelo Costamiglia Rombaldi from Brazil, Hospital de Porto Alegre. Welcome.
Thank you.
Dr. Charicleia Demiri for Friends Hara from Thessaloniki in Greece. Welcome, Hara. Dr. Giulia Fusi from Hospital Le Scotte of Siena. Dr. Caroline Gargioni Barreto from Brazil, Hospital de Porto Alegre. And Dottoressa Federica Pederiva from Buzzi Hospital in Milan. Welcome to everyone. Now, I ask to Michela
Okay, let's pass to the Master on Pediatric Urology. I start with the attendance who completed the Master in the academic year 2021-2022, because also for you we have the hospital degrees. Obviously, we will send you this paper. It was an honor for us to have you part of our school. So, Fabio Beretta, congratulations. Silvia Cavaiuolo, Vincenza Girgenti.
Thank you.
Maria Paola Lanzillotto. Catarina Stalberg-Glatz. E Aline Vaz da Silva. Congratulations to all of you for have completed this course with us.
Thank you very much to everybody.
Thank you.
Then we pass to the attendance of this year who discussed their final dissertation. Also for you, Professor Lima prepared the books of our school with the drawings of Professor Domini, who was the master of the school. And also for you, there are some dedications. A Paolo Cagliazzo, entusiasta e attento chirurgo pediatra, con l'augurio più caro, Mario Lima.
Grazie, professore.
Ad Eugenia Piro, attenta e bravissima collega, curiosa ed entusiasta, Mario Lima.
Grazie professore, è stato un piacere e un onore.
Also for you, there are our jackets that for the master in pediatric urology are red and not blue, but also this is also a sign of that you belong to our school now. And the best thesis, okay, goes to Eugenia. Congratulations, Eugenia, for your thesis dissertation.
Grazie.
This prize is for you, and we will send you, obviously, the prize and the certificate of best thesis dissertation of this academic year. Congratulations.
Grazie professore, davvero un onore è stato.
And now we will proceed with the attendance of the next academic year. Dr. Bassam Khalid Abed Al-Kozi from Mosul, welcome.
Hello, welcome. Thank you.
Dottoressa Francesca Caravaggi from Parma, welcome.
Good afternoon, thank you.
Dottoressa Venusa Forenza, che viene da Genova.
Thank you.
Dottoressa Francesca Nassim Ben from Siena.
Good afternoon, thank you.
Dr. Reduje Thomas, our resident, welcome. And Dr. Elettra Vestri from Milan.
Thank you.
Welcome to all of you. It's an honor and a pleasure for us to have you with us. Now I pass the word.
Now,
That's the thing I want to tell you that we will send for the performance, the certificate and the jacket. We have our address. Okay. Now I ask to Professor Liva to close.
yes, for me it's a pleasure to close this very, for me, interesting afternoon and meeting. And Merry Christmas, all of you and your family. This is the picture of Bologna in the Christmas time. And I hope is a new year, a year of peace. And for the new attendant of the two master, we see in Bologna for your stage. And I think is a good year for all of you and for us. Thank you very much, and to next year for the new inauguration. Arrivederci. Thank you, Jean-Bret. Thank you all the friend that have presentation of this very interesting afternoon. I hope that the simulation, the new teaching, and the modern teaching increase in pediatric surgery. Arrivederci. Goodbye.
See you tomorrow.
Oh, see you tomorrow.
Thank you so much, Mario. Thanks
Bye-bye.
to you too.
Olga,
Thank you so much.
bye. Bye.
Bye bye.
Arrivederci, buonasera.
Grazie, arrivederci ancora, professore, grazie.
Grazie, buonasera a tutti.
Arrivederci, buona serata.
Arrivederci.